So let's go to the questions and answers. Couple of options. I think folks who have questions can raise their hand, and Amanda will unmute your phone, and you can ask the question in that manner. Or you can put your question into the chat, and we'll queue those up in the chat. We don't have any questions or comments in the chat yet, so I didn't encourage you to use the chat during this period of time. I'll start by asking a question I've been kind of dying to ask folks interested in this topic, and that's, have any of you run into conflicts or struggles because of coding issues? Let me give you an example. I was presenting at a hospital about the implementation of OpenNotes and talking about the documentation issues, and an internist raised her hand and stopped me and said, John, I'm concerned that you're in conflict with our code consultant, who has told us that when we use the term non-compliant, they're able to use a higher billing code. Have any of you all, or feel free in the chat, or audience members, have any of you all run into that kind of conflict?
We definitely found that in the survey. One of the things that came up a lot was this issue of, we're supposed to say when we use time for coding that more than half the time was spent in counseling and coordination of care. And so it needs that phrase in some fashion. Now, when that phrase was in there, patients reacted to that by thinking we're complaining that we spent more than half the time counseling. So, and yet that phrase, at least as far as I understand, needs to be somehow in there to code by time.
Anyone else with comments along those lines?
I mean, this is Jared. I haven't had that exact experience about the non-compliant phrase, but some of it seems a little bit like an interpretation of the coders, because the underlying issue is the same whether you use the term non-compliant or adherence challenge difficulty. But I agree, it's hard to kind of bridge those divides sometimes between the clinical world and the patient experience, and then the billing and coding kind of environment. So
this is Jeremy. So not so much for billing, but actually we found that some of the long n-grams were phrases that had been mandated by the hospital. For example, if a signer of a note was late, if it was an attestation of a note, they were required to put in this very long, sort of confusing phrase. And that's one of the things that went away with OpenNotes, because it was confusing to everybody, including the patients, to see this, this statement about the fact that the note was signed late in the chart. So that is driving some of the changes that we saw, actually.
Thanks, Jeremy. Questions? Anyone out in the audience have questions?
I actually have a question. This is Amanda. I was wondering if, because several of you talked about labeling and terms like different ways that people feel stigmatized or judged. I'm wondering if any of you have had personal experience with that in your practices and how you've addressed that when it's come up.
This is Steve. I'm not really sure how to answer that. I mean, I think that I've been practicing for many years under the assumption patients will read my notes, but I can't think of a particular situation where I had a discussion with somebody about those terms. Maybe someone else has.
I can raise something, which is, I recall a patient, this is not exactly on point, but a patient who had something very difficult happen with a family member. And in order to support her and to remember it, I included it. This is around the issue of details. And it was shameful to her her, even though it wasn't about her. It was about a family member. And she was kind enough to tell me later that she wished I hadn't included that. And so I learned that somehow I needed to put it, as many of you just mentioned, more in a more shrouded fashion, so that it would trigger me to remember, but not shame her or in her mind stigmatize her.
Okay. We've got a question for Dr. Warner in the chat. I'm a consumer health informatics researcher who focuses on consumer health terminology, but also a rare cancer patient. Wearing both my hats on my head, I am curious. Are there portions of specific clinical documents that you, as an oncologist, consider immune from rewriting? Example, many patients in the support groups are very confused. Many patients in the support groups that I frequent are very confused by the term, quote, KI-67.
Jeremy wrote that he is having network issues, so we'll come back to that question. This is Liz Salmi from OpenNotes, and since I'm talking, I'll ask my question out loud. I wrote in the chat box, but I'll say it out loud. Just curious, for those of you academic hospitals, which 3 of you are, what advice do you have for those who, other clinicians who are working with students and residents who might be starting the note? And are you doing anything special to check their note before signing off on that note? And also, how are you teaching future clinicians about OpenNotes to kind of grow up in this environment?
Hi, it's Jeremy. Can you hear me? I'm back.
Yes.
Okay, that's all.
Go ahead.
I'm hardwired in.
Go ahead, John.
Let me try to tackle both. So first of all, I mean, getting to what others said about if you say it, the way you say it should be the way you write it. And like, if I was ever talking to a patient about KI-67, I would definitely explain, what it is in layman's terms. And so if I'm explaining it out loud, I should probably be documenting similarly. That being said, a pathology report, which is something that you refer to, that is not a note that is a note to a specialist, right? Like a pathology report is essentially commissioned by the cancer doctor to give them the highly technical details that they need. And then it's really up to the cancer doctor, the treating oncologist, to translate those findings into words that are readable both by other clinicians as well as patients. So, but plenty, exactly, and patients see it anyway, and also plenty of clinicians just copy and paste the path report right into their document. So that's not a great answer, but we have to preserve the technical details, I think, but also interpret them in such a way that the note is readable. And this is another kind of project of mine, we should get rid of our current paradigm of progress notes altogether, and have something that's more dynamic and linkable, like a wiki format, in which case you could have a glossary of terms, so that everything that's kind of weird or technical can be linked to, and you immediately get the full definition, whether internal or from a third-party website like Wikipedia. But enough about that. Come to our AMIA session that Liz and I will be speaking at to hear more about that. So in terms of the other thing about the academic medical centers, I think that's a great question. I think that I'm pretty sure that it's not part of the medical student curriculum, but it probably should be. That first of all, documentation in general is not part of the medical school curriculum, which leads to all kinds of problems, obviously. But documentation for the intent of transparency, both with colleagues as well as the patients, just has to be part of that curriculum. And how to do that, I'd be curious to hear from others from academic or other centers.
Hi, this is Gordy Schiff. I have a few questions. Can you hear me?
Go ahead, Gordy.
Yeah. First of all, this has really been great. I guess I'm hearing they're moving from sort of taking away the negative edge, right, all the pejorative words, to think, and we haven't really come very far on that. Already there's a lot to do, but how to turn the notes into something more positive that is part of education, building a therapeutic relationship. So I don't know. This is great, but it's just it's just the beginning, really. And I think I'm sure you all would acknowledge that. I guess nobody said this, but I have to speak for the PCPs out in the trenches. Who has time for this? You don't want me to write follow-up or GS 14. I have to write it all out. Of course, there's scribes, but short of that, we're really up against this other constraint. So I guess we could talk a long time on that. Let me mention another thing that has to do with, I guess, police used to keep dual reports. They used to keep the official report and then the unofficial notes of what was really going on or what do you really think is happening with the patient. I fear there's a little tendency for us to do that. I don't want to really write what I really think about the patient. I'll keep those notes separately. How do we do that? I heard some tips about how to do that in a way that's not too stigmatizing. And I guess the final thing I would just say is voice recognition has just got to be front and center with this. It's really come a long way. If you haven't tried Dragon anywhere, it's better than the stuff even on the desktop for your phone. So just something to throw out real quick. I know we're out of time, running out of time.
Yeah, thanks, Cordy. This is John Santa. One thing I would say is I've been so impressed. I mean, I'm at the end of my career. I've already ended my clinical career and near the end of my administrative career. I have been so impressed working for OpenNotes how much is going on asynchronously that us old doctors had no sense of. I mean, in this world, people are thinking, they're reading, they're talking, they're doing all kinds of stuff when they're not at their doctor's office. And so you're right, this is an evolution that's challenging, but, I just don't see how we can do anything but dive in and keep at it. And ultimately, I think folks are going to get incredible benefits from this asynchronous world. And there's places like Mayo that are really, I think, doing a great job, and many of your places are. We got to do more of it. I think with that, I see it's 11 o'clock, and so we'll end on time. Again, appreciate you all coming. You see Amanda's email on the screen now. Email her if you are interested in participating in a learning collaborative. Further discuss and perhaps do some things related to this issue. And you'll be getting notice when the recording of the webinar is available, and I think the slides will be available. So thank everybody so much. Bye-bye.
Thanks to our presenters. Thanks everyone for joining.